Great day for us here, and we're we're here doing a number of things. One of which is uh, celebrating the legacy of this handsome man up here, Emil Tanagho, and Peter's going to introduce our esteemed guest. It's going to be a great day. We're also going to hear research presentations from our residents, and hat trick to Dan and the University of Washington, because Dr. Hampson got the inspiration for the day set up from her experience being a fellow at University of Washington. And so we're grateful for that influence, Dan. But this is a very special day, commemorating our graduating chief residents and fellows. And the day is honoring the legacy of Emil Tanagho, who was a giant in urology and a giant at UCSF, and massively influential on the course that this department has taken. Emil became chair in 1976, and under his influence, this went from a division, the Department of Surgery, to a department standalone. He was chair for 20 years until Peter took over in 1996. Certainly a giant in the field, pioneer surgeon scientist, key to implementing InterStim and other discoveries, and also an innovative surgeon in female incontinence. I mention this every year, but I think his biggest impact, got this row here of legends, third row back, the people that Emil recruited: Jack, Dr. Lude, Peter, Marshall, Larry, many others, helped build this department and helped Peter when he was starting and growing this department to what it is today. So it's a real pleasure for me to turn it over to Peter to introduce our esteemed speaker, Dan.
This is indeed a pleasure and honor for me. So little time, so much to say. Dan Lin, simply a star. I reviewed Dan's CV last night. I know a lot about Dan over the years. I know his academic productivity, his research funding. He's a mentor to many. The thing that surprised me most is Dan was born in Cleveland, and nothing against Cleveland, but I had never visioned. But when I was thinking about this, is that you do have that kind of Midwest friendliness, probably from Cleveland, but as I mentioned, Dan's simply a star, burning very brightly. He's the chair of the department at UW, and he holds a Pritt family chair. His research productivity is amazing, and you just need to look at his CV, see his track record of peer-reviewed research support. He runs the Canary Pass, which we're supportive, which I think has really changed the face of active surveillance for many. Dan went to Stanford. We don't hold that against you. Many of us are Cal graduates. And then went on to Vanderbilt. Also, like some of us, went to Sloan Kettering to get his fellowship in urologic oncology, and returned to UW. He's on several panels, guidelines. As I mentioned, his research interests are broad and very, very impactful. What was very amazing, and it's not amazing to me at all, to me in this room, is Dan's a wonderful mentor, and actually got recognized for his teaching even as an undergraduate at Stanford in biological sciences, but that kept up during his training and then as faculty. And of course, he's trained several in this room: Lindsay, Mara, and Annabelle. So it gives me great pleasure to introduce Dan Lin, and we're looking very much forward to this.
Well, thank you, Peter, and thank you, Ben, and thank you all for having me. I'm really honored to give the Tanagho lecture today. I had the opportunity to meet him only a couple times, Honestly, despite the fact I hear he was a very friendly, kind guy, he scared me. He scared me. He was very stern. It was back in the day that when he interviewed, you just had to be on point. But I really am honored to give this talk. And I think today I was reflecting this morning, personally, is one of the reasons I went into academic urology. I mean, a day like today to see all the people here, and we'll hear about all the progress and motivation and inspiration of all your projects today. I mean, a week from now, I'll be in your shoes in the audience when we have our graduation. So I'll share in this time of celebration for the graduates and training the next generation in the future. So it's been a real pleasure to be invited here, and I'm happy to give this talk. Before I start, just a couple of disclosures, none relevant. Before I start, as Peter said, and Ben, there are some interplay with us, and it runs pretty deep. It runs a lot deeper than I know either from this history. But there are some connections right now on your faculty, and here are some of them. Justin and Rishi were both residents with us, and then Mira, Annabelle, and Lindsay, as Ben said, both walked our halls up in Seattle and trained with us, and I was really happy to be able to interact and meet them for the first time at UW. Likewise, we have several on our faculty who are also graduates of this program or have walked these halls with what Ben said, the legends, many of the legends of urology, of all history of urology. And here are some of them. You recognize Maya and Claire. I had a meeting with Maya yesterday. I meet with all the first year faculty once a month. It's one of my best meetings of the month, sitting across from her. And she's putting an R01 in this October. She's lighting it up and doing an unbelievable job. And then, of course, Claire, I'll talk about Claire a little later because she's this afternoon, she's involved in a lot of research with me. But you know them very well. They spent years with you all, maybe right here in this room. And then, of course, Matt, Tom, and Hunter all trained here as fellows. And again, we really appreciate you bringing them back to us in a different form. Then there are a lot of others. I mean, I'm missing some of them. I'm pretty sure I'm missing some. But Helena, Mark Delara was one of our residents. Adam came up to see us. Ryan C., of course, was down here at a time. Ian Metzler, Chris Welty. There's others. I'm pretty sure there's others. But I was joking before about this joint kind of finishing school that we have for each other. And now that I'm the new chair, I talked to Ben about hopefully we can continue a rich tradition of interplay and interaction and connections and so forth. Because really what I think maybe is the ultimate connection between us in many ways is this commitment for innovative research, like there's world-class education and teaching, no doubt about it. And I know that Dr. Hampson and our program, we have some educational initiatives together, our M&M conference, some of the other things we're doing. It's really wonderful. I want to keep that up. And then, of course, just outstanding clinical care that you deliver here. And I think that we deliver up in the Northwest. So again, humbled and honored to be here today, and I'm going to move on to the talk, which is about screening. Peter mentioned one of my big interests is active surveillance. I think that'd be like preaching to the choir here. So I'm going to look at my next interest more recently, which is in the screening area. I had the opportunity to be the chair of the AUA guidelines, the update recently for prostate cancer screenings for the trainees. Some of this is testable things. So I wanted to start with some more testable things for you, for the trainees, and then introduce some things about genetic testing, which again, I think not only is testable, but is very relevant for how we treat prostate cancer. And then at the end, talk about really the next interest that I have. And I think we're in collaboration with UCSF about screening and where we're going with screening and where we're going particularly with genetic testing and where that's going to end up. So for those that haven't been involved in the AUA guideline process, who has been involved in the guideline panel? Yes. And I know many have reviewed it, but I want to, mostly for the trainees, I think, to understand why are these guidelines and where do they come from? Like, what's the backing behind the guidelines? Well, I can tell you how the process went for the screening guideline. We convened in 21 for the original panel. We convened again just recently for an update. They get updated pretty frequently, maybe not as frequently as they should. This guideline actually was well over 10 years old. We studied multiple. There's over There was actually 12,000 texts that came down, but we actually narrowed it down to about 1,200 texts. We had an update in the 2 years that follow that. And then you'll see guideline recommendation and statement types. And I think, again, this is important for you to understand why and how we came about with the guidelines. There are strong, moderate, and conditional recommendations, and they turn out with clear statements. So you'll see statements that say should. Should means strong, good data. And there's a lot of mays. You will never see the word consider in an AUA guideline. For those of you that look at NCCN, they say consider this, consider that. What's consider? Particularly consider in the legal realm, but we don't use consider, we use may or should. And then there are principles and expert opinions, which we won't go over. So as I said, the AUA screening guideline first came out in 2013. It got updated in 2018, and it was 5 statements. It was basically when to start, how often to do it, maybe a little thing about when to stop. There was very little in the guideline. It clearly was pillaged a little bit because it had very little in it. We were directed to say, now incorporate other things. 35 statements. Sorry, the residents, you have to know 35 statements. Now, all of them, not all of them are high bar statements, but we said to ourselves, we were put in charge. Weave in biomarkers, weave in imaging, weave in biopsy techniques. And so we did that, and we really split it between screening, initial biopsy, repeat biopsy, and then maybe a little bit about biopsy technique. And I'm going to show you some of these. For the sake of time, I'm not going to go over all 35 because I want to get to, I think, the more interesting part, which is the future and some research, and hopefully have some motivation for going forward. So the statements were derived, and I just want to let you know that there was an external review. The external review comes back, and there were 770 comments. And I absolutely know Dr. Kuperberg has some of them because I know him well enough that when I was reading the comments, I was like, this is from Matt for sure. But we get a grid, and it's 770 rows long, literally. And there's a column of our response. And so we had to respond to all of them, and we did. And then it goes for review, and I'm going to show you some of them. Okay, so I'm not going to go through all of them. But I think that, again, some of them are testable. We started with the lowest of low bar ones, which is about shared decision making. So obviously, engage in shared decision making. It's a low bar. There's plenty of evidence to support that based on someone's values and so forth. But then we go into initial screening, and what do we do for screening? Okay, and we said yes, use PSA, again, a low bar, evidence level grade A. For newly elevated PSA, again, repeat the PSA. That's pretty clear. We had a statement in there about antibiotics originally, and then we decided to take it out and just put it in the text. Don't give antibiotics. It's been very clear that that's not necessarily a strategy. You see your primary care colleagues do it all the time, though, right? May use DRE. It used to say should use DRE. But if you look at really the evidence of DRE, and the primary care people came to me and said, thank God we don't have to do a DRE. One of my patients called it Dr. Dre. Says, don't give me Dr. Dre, So, and we said may for a reason, because for a screening tool, DRE is really poor. But if PSA is already elevated, then yes, it actually works pretty well for staging. Okay, so we say for a screening tool, may use DRE, and then should not use PSA velocity. So just because the PSA goes from 0.5 to 1.5 is not the only reason to get a biopsy. I think that a lot of primary care people were saying, hey, PSA went up a point, that I think we should do a biopsy, or I think you should see the patient. Well, I say repeat the PSA, it's okay, depending on the risk groups, which we're going to talk about in a minute. So when to start? And again, this was a little bit controversial. It used to say start at 50 or consider it 54. There's all these groups out there. We actually say maybe get a baseline one for someone at average risk between 45 and 50. And there are reasons behind that, which we'll get into. And then if someone's at higher risk, increased risk, start at 40 to 45. Okay, we're going to go through this group quite a bit in the second half of the talk. There's data to show this, particularly in people of African ancestry. We showed, and this is from Ruth Etzioni and the Michigan group, showing the lead time in Black individuals is it's somewhere between 3 and 9 years, and we chose 5. Okay, so that's why we chose 5 years earlier for screening in that. How often to screen? Again, I tell my primary care colleagues this all the time. You do not have to do it every year. We say every 2 to 4 years. All right, and they have a lot of things to think about. Diabetes, cardiology, colon cancer screening. They have a whole list of things. When I go to my primary care guy, he looks at me and he says, "Okay, you ready for the list?" I'm like, yeah, sure. And he ticks it off. He even asked me about Last time he asked me about, fire alarms in my house. Do you have guns in your house? I mean, they have a whole list of things they have to do. Prostate cancer is not one that they really want to do. But I say, hey, do it every 4 years. You can do this once every 4 years. And that's what I tell everybody, at least. We may personalize rescreening based on the PSA, based on other things with regards to the prostate cancer risk, and then use a risk calculator. We say that. The issue I have with risk calculators is that depends on which risk calculator you use, gives widely different results, and it's very frustrating. Okay, but you try to use a risk calculator, and then really importantly, if the risk is sufficiently low, forego a biopsy. And there's a really nice screening algorithm we have. I won't run through it in the chart. Importantly, and I'm doing this now, and I still see patients with elevated PSA. Mostly patients come to me with already diagnosed prostate cancer, but I do tell them that, hey, if we're going to go walk down this path a little bit, I'm going to inform you that we might find a cancer that doesn't need to be found. I think it's pretty important. This will be the topic of this afternoon seminar for those of you that can come for active surveillance. What about for initial biopsy? I would say that statement 13 probably I drew the most fire for, because it's a may statement, and it says may use MRI for initial biopsy. I think the Europeans wrote me right away and said, why doesn't it say should? What's wrong with you Americans? And I think, and we can get into this in the QA, I'm happy to talk about it, but clinicians may use MRI for the initial biopsy. So someone comes in with elevated PSA, do you have to get an MRI? No. Am I mostly? I am, but it's not required from the data. Radiologists, of course, should use PI-RADS. We put that in for the radiologists in the group. And then for those that has a suspicious lesion on the MRI, should perform a targeted biopsy and may also perform systematic biopsies, because we find a lot of cancer in those systematic biopsies. Now, are they just adjacent to the lesion because we just missed the lesion? Maybe, but we should perform systematic biopsies. And then in the absence of findings, if the patient still has an elevated risk of finding cancer, you can still do the biopsy. And again, this is the other one that the Europeans said, why do that? You'll find it on the next screen. We can talk about that for the initial biopsy. Biomarkers, honestly, we hedged a little bit. We said may use if it would influence the decision. Again, we can get into that a little bit later. There's a nice algorithm that's put forth. In the repeat biopsy setting, it's a little different, because if you look at the data, repeat and initial, they have very different results, and tests perform differently if someone's already been sampled. If there's prostate's already been poked 14 times or something, then biomarkers and imaging perform differently. So first of all, don't discontinue screening solely based on a negative biopsy. We've seen that. People ask us about that. Don't use a threshold saying, oh, I got a biopsy at PSA of 5. I'm not going to biopsy again until the PSA of 10. I hear that sometimes. We say, no, don't do that. Continue screening and reevaluate the normal screening intervals, like 2 to 4 years is okay. And then should use a risk assessment tool, in particular one that incorporates a previous negative biopsy, because that does affect the risk of these calculators. After the initial biopsy, if low probability, don't reflexively perform a biomarker. There was a study, actually, I think it was by Mike Leitman, who was one of your past fellows, looking at regions of the country and biomarker use. And he found that there were some counties that were doing everybody getting a biomarker with a negative biopsy. That was just their reflexes. Everybody got a biomarker study if they had a negative biopsy. And we said that's really not indicated. And there are people that you should do a biopsy, but not everybody. After a negative biopsy, may use, of course, blood or biomarkers. We had a couple statements on PIN and ASAP. One is if it's just focal PIN, you don't have to perform another biopsy. That's already been in Campbell's for a while, but we decided to put that as a statement. And then a newer one in the update, there was a pretty recent study looking at ASAP showing a pretty high PPV or a predictive value of finding cancer at the next biopsy. So we put a statement in there saying including another biopsy in a patient with ASAP. With regards to MRI, and again, I think this is less controversial. The Europeans didn't give me grief about this one, but if they have now no prior MRI, of course, get an MRI in the repeat biopsy setting. In patients who have had a suspicious lesion, of course, you could, if they don't have a suspicious lesion, of course, you can proceed with a biopsy, even with no lesion, if there's a high enough risk of finding cancer. And then lastly, if they have a suspicious lesion, of course, hit the lesion, but also you can do systematics. Again, this is a little bit for the legal issues that are around surrounding biopsy use. And then again, there's a nice biopsy algorithm. The last thing we addressed was technique. Now, I know that you all here do transperineal. We do both transperineal and transrectal. Get two needle cores per target, of course, and that's treated as one core. So if you do 3 or 4 biopsies of a target and they're positive, it's treated as really one core in the numerical scale when you're counting up how many biopsies. And then we put here, and again, a lot of grief from the Europeans and Australians, actually, they call me both, transrectal or. And as you probably know, most of Europe, as well as I think the entire continent of Australia, are doing them all transperineally. And we can go into why. And I think that it is useful to understand. I think it's good to have both in the armamentarium for various reasons. But you look at the data. I mean, these are the data. And there are more emerging data as well. If you look at infectious complications between the 2 big randomized clinical trials, one of them was a single center trial showing really no difference. The other one initially showed no difference or barely a difference. And then with increasing numbers and increasing time, it did look like there was a little bit of a difference. There are 2 other studies showing very little difference, if not no difference. The one good thing about transperineal is the antibiotic stewardship issue. You know, there's some don't. Do you all use antibiotics here for transperineal? Sometimes, yeah. So, and we do too. Sometimes a single dose or none, depending on the patient. So there is an antibiotic issue with both that. There are 2 other big trials looking at, do they detect more cancer transperineally? And from the data that I've seen, the preliminary data, it does not show that. Okay. Both published in the literature. This is the update that just came out last month, at least in the print version. You can look those up, and happy to answer questions after the talk. All right, we can break now if any questions. Any questions now on the screening part? Matt.
First of all, thanks for joining us. Thanks for your leadership on this. I really do think it is the best of the screening guidelines. There's a lot of complications. 2 questions on it. Number 1, is it silent on threshold? So the primary care docs don't know 4.0. The guidelines are all silent on threshold.
Yeah.
And I think it causes a lot of confusion in primary care, especially as you move the age up.
Yeah.
You know, there's no guidance about earlier.
Yeah,
action.
sure.
So that's one. The other question is, how do we get this out to primary care? Because they all still look at testing. So I do think this is the best of the guidelines, but primary care has no idea.
Yeah. So the first is on the thresholds. The thresholds are in the fine print, unfortunately. We thought about doing thresholds, and the second half of the talk, we will talk about thresholds as it pertains to patrol. And I think that'll be good teaching for the residents and for everybody with their primary care people. We didn't do it because, as you know, the age-associated ranges, there are pros and cons to that, right? And we can talk about it, but the thresholds we did not do. With regards to getting it out to primary care, that's a tough one. They're bombarded as well. You know, I have one of my good friends is a primary care provider, you know, and he tells me all the time that it's really hard. Which guideline do you look at? The family practice one, the USPSTF, the AUA one? Oh, you urologists are all biased because, you know, you want people to get biopsy. Now, we do have, I think I agree. You know, I guess I have a conflict of interest about it, but humbly, it's thoughtful. I mean, it does say watch out for low-grade cancer. It says those things, and I know you're a big proponent, and I think that much of your work here and Ruth's and others made the USPSTF change from a D to a C. All right, a C. Last I checked, a C is not that great, but yeah, it did change back to shared decision making. I don't know. I mean, if you have any ideas, I'd love to hear ideas, or anybody here, how to get the primary care providers to see these guidelines. But they got a lot on their plates. Yeah. Annabelle?
You mentioned a couple times about how these are interpreted in a legal setting and that kind of thing. When guidelines members are writing and thinking about these statements, are you using your own personal experience, or does the AUA provide any sort of policy guidance in kind of a more comprehensive analysis of what they're seeing nationwide around?
Yeah, so it's all there's a methodologist, a very high-priced methodologist, basically that runs through everything. It's evidence-based. At the same time, you're right. We all sit there and think about our own experience because we see these people, and so it's hard to disassociate yourself from your own experience. But it has to be evidence-based. That's what the evidence base is with regards to A, B, and C, should, may, conditional, strong recommendations. So it's a little bit of an inexact science. I will say this: I'm a vice chair of a NCCN panel. I've been on an Astro panel. The AUA, I think, does it the best. I mean, the NCCN, it's unbelievable. In the AUA, you got to leave the room. You got COI, like literally leave the room. NCCN, you're hanging out, even if you're not on the payroll. So nothing against that, but it's more of a consensus rather than a real guideline. Max?
You just touched on risk calculators and didn't delve into that. Do you use them much I mean, I think patients like to hear some numbers to give a perspective. And so even though there are differences, 5% is different from 25%.
Yeah.
To give objective information, and amongst them, what do you tend to use?
Depends on who I'm seeing, honestly. I mean, remember, I live in the world of Boeing and Microsoft where they love numbers. I mean, they come in with the calculator themselves, almost. And I will say what's frustrating to me, and I'd love to hear those of you that work with calculators, if you put in a patient's information into PCPT, and then you put it into PCBG, and you put it into Rotterdam, you're getting 3 different answers. And sometimes they're wildly different. And I tell people, I'll usually show people the PCPT and the PCBG if they're interested, and sometimes they bring them with them. And I say the truth is in between. It probably is in between. And I think we have done it enough to kind of know it here. And if they don't want to care about seeing it on the screen or on a sheet of paper, I'll just tell them, I think your risk is probably 30%. And of the 30%, 1 in 3 is going to be aggressive cancer. But I think their calculator's got a lot of problems. And it's not based on contemporary data. And so having said that, it's probably better than nothing. It's probably better than telling a patient, oh, you need a biopsy. I tell people, you need a biopsy, most likely it's going to be negative, just so you know. And here are the risks, because it is most likely negative in those with a PSA less than 10. Peter?
Yeah, I think you're a little too hard on NCCN. I lived there for many years. So I think it's and it actually is a guideline that's actually more read than
it is way more read.
So yeah. I do think there's an interesting difference between may and consider. So may is pretty passive. Consider means you should think about this. If you do 1,000 PSA, 1,000 men in the U.S., about 250 will have elevated PSA, and NCCN does have a cut point because I think we want to have some kind of cut point. There's a lot of unnecessary biopsies being done, and yet you still advise it for the negative biopsy. So when you think, consider means you should really consider using these things, and may to me is passive. And I see too many people getting unnecessary biopsies, poorly performed biopsies, and not getting the imaging that needs to be done. Stronger statement, I think, would be good. And then you're right about I reviewed the guidelines before they released it for the C&D, and I showed them that Matt had done as well. Showed them that urologists were getting it. That in fact, over-detection is an issue, and responding to that. And I think that was helpful. We're going to see new guidelines. It's not up yet, right? The revised guidelines.
For which?
The
localized.
No, task force.
Oh no, it's not. So, yeah, I know the person that's in charge of the evidence review for the USPSTF, and so they're still in evidence review.
Okay, so it's supposed to come out very shortly, and this is still a big deal. You saw the report in the UK.
Big deal.
The UK was going to recommend against this.
Mm-hmm. They were only going to recommend screening in the group I'm just about to talk about now, and it just came out last week, and so. We'll see what happens.
Well, I hear the government's going to intervene and say
yes.
And in Australia, they have it's a national adopted policy.
Yeah.
It's still a great controversy ongoing about it.
Yeah. So anyway, great. I appreciate that feedback. I will say that it is true. Consider is definitely more directive than may. But consider on a legal level, consider does say exactly what you're saying, which is if you didn't consider it or if you didn't do it a certain amount of time, you're going to get sued.
Right. So
or it's okay to get sued.
And then the issue is who you're advocating for, the patient or the urologist. Like failure to diagnose is a big medical
a huge thing. I think that advocating for the patients, but and at the same time, I think that it's evidence. It still is. If you look at the evidence in the initial biopsy setting, even the Europeans' own data, and I show their own data all the time, it is not statistically significant, and it's not even clinically significant, the increased detection rate with MRI. Now, again, this was data from 8 or so years ago, and it's because MRI, and we'll talk about this afternoon a little bit, MRI has issues. We're going to solve those issues. I was just talking to Marshall before this talk about the AI and computer aided diagnostics, and MRI is going to get fixed. I think we'll fix MRI such that it will be a should. Yeah, I hope. So moving on, and this next slide you've probably seen because it says courtesy of Matt. I think he was the first one that made it, and I decided I'm not updating anymore because it needs too much updating. But there's a wide scope. Okay, I'm not gonna the one that I want to really think about is this, which is I think that genomic variants or what the patient is born with in the germline really is the spectrum. Okay, and that's what we're going to talk about for the last half of the talk here is genomic mutations, in particular the BRCA mutations. Again, kind of biology 101, you all know this. Somatic mutations, something after fertilization, germline mutations of one of the germlines. Of course, every cell in your body, every cell in your patient's body will carry this mutation, and then half the gametes to pass along. Okay, so we're going to talk mostly about the germline mutations now. We can talk about somatic. We'll have a little bit about somatic later. We know that these inherited mutations confer risk. We know they do. There's probably an interplay with exposure, diet, or something like that, lifestyle, environment. We also know that for prostate cancer, there are many mutations or variants. I call them variants when I talk to patients. It's not mutations. They don't like to hear they have a mutation. But the variants that are very common are kind of low risk. So they'll confer maybe a 10%, 20% increase in risk. But the ones we're really talking about are down here, which are the rare variants that confer a very high risk. And we think that that's probably only 5 to 10% of prostate cancer. However, I think as we learn more about variants, the two smaller pieces of the pie will just grow. Because I see patients in that second bin, familial prostate cancer, they have a lot of prostate cancer in their family and some breast and ovarian cancer, yet they screen negative for the relevant genes. Why is that? It's probably because we just don't know what they are. They have something genetic. We just don't know what it is. We call it familial at this point in time until we can really find the gene. The majority are still sporadic. We were one of the first groups years ago, 10 years ago, to show that about 1 in 8 patients who have metastatic prostate cancer harbor genes that are in the DNA repair pathway. That number probably is a little less, but because we have a highly select population that we took this from. But we were one of the first ones to say, hey, we should really start looking for these genes even earlier along the course of disease. Why? Because these increase the lifetime risk of having prostate cancer by at least 5-fold, and by age 65, almost 10-fold. If a person harbors particularly BRCA2, their chance of being diagnosed with prostate cancer by age 65 is at least 8.6 in this paper, higher. And the cancers are worse. They're higher grade, higher stage, they're worse cancer-specific survival. And then it comes like which patients should undergo this. And again, this is in the guidelines. This is in the screening guidelines, which we can show. Family history goes beyond prostate cancer. So this is maybe not the most typical pedigree, but I see patients like this, that the patient comes in, and when I talk to them, he says, oh man, my sister had ovarian cancer, my mom had ovarian cancer, aunt with breast cancer, and so forth, and even a niece. Fairly common. This just screams out to me some sort of syndromic inherited variant. And in fact, in my template, or all Epic template, it actually says ask about these things just to make sure I do. And I do because I think it is very relevant. And there are screening guidelines. Of course, there's how old at diagnosis, are they metastatic, and so forth. And these guidelines for many, many years, the NCCN, many years stopped at breast, ovarian, and pancreatic. And it really aggravated me. And finally, they put prostate on there about 2 or 3 years ago. So, and Heather Chang represents us on this committee for high risk assessments. And in there's a big guideline for prostate cancer susceptibility, in particular for these such as ATM and the BRCA mutations. And it's a big list of things. And I don't want to, for sakes of time, we're not going to run through all the things, but it is basically the standard thing: more than 1 or greater than or equal to 1 blood relative with any of the listing there, breast cancer, their own personal history of breast cancer. I've had patients come in with a diagnosis of breast cancer and now doing PSA screening because they were found they had a mutation in BRCA1. Ashkenazi Jewish ancestry and so forth. You can read it down there. But also the last one there, which is intermediate risk prostate cancer with intraductal or cribriform, is kind of questionable. There's a lot of people there. A lot. Do we have to test all those people? I don't know. We're not doing it yet. I don't know if you're doing it here yet, but that's in the guidelines. And there are a lot of options. We have these kits that we have in our clinic. We just say, hey, take this kit home, or right here in the clinic, just spit, send it off. Now there's some issues about testing and insurance coverage and prior authorization. We work through that. And then there's this issue of test results, because there's either a positive or a negative, and then there's this VUS thing, and then a variant of unknown, significance. And people come all the time. Oh, I have this terrible mutation. Well, no, it's a unknown. I think those are probably, some of them probably are eventually going to be emerging as real variants. The caveats is that people also come to me and say, I'm fine. I got my ancestry or my 23, when 23andMe was around, I got that, I'm fine. Well, it's not the same. They're just looking at kind of founder mutations, sort of ones that are just at the tip of the iceberg. We want to look at the whole genome. And I do think eventually we will be to the point you'll have your genome on the back of your driver's license or something. Everyone will know their genome at some point in time. So back to, what are the implications? Okay, there are a lot of implications, and I want to get to the end where we're going to talk about what we're doing next. So I showed you this before, and again, those at increased risk, germline mutations. The NCCN came in here, prostate cancer detection, again, started at age 40 for high risk. Who are those people? Germline mutations. Okay, why? There was a pretty big study in Europe, and it was over 3,000 people. About 2,000 of them had a BRCA variant. Okay, and this was the first pass. So this was 5 years ago. I'll show an update of this later, but just remember this. They used a screening trigger of 3. So if the PSA went above 3, it was a trigger for a biopsy. And just showing you an example here, down here, BRCA2 carrier, BRCA2 non-carrier. If you look at that, BRCA2 carrier, only a third had 3+3 disease. Only a third had that low risk active surveillance, the kind of maybe not even cancer according to Cooperberg and all. But 2/3 had clinically significant cancer. Okay, compared to over here, 3/4 had, well, maybe they didn't have cancer. Okay, but they were biopsy and they found 3+3 cancer. Okay, so just keep that in mind. There were higher incidence of cancer in the carriers, younger age, more clinically significant tumors, and we know those tumors don't do well. In fact, when we look at modest numbers of patients who have had surgery or radiation, carriers in red, non-carriers in blue, clearly you can see for metastasis-free survival and cancer-specific survival, they do worse. There's no doubt that those people do worse. We also found that the carriers in these mutations are very sensitive to even chemotherapy, of all things. And we didn't ever think that prostate cancer is not that chemosensitive. But this was published again 10 years ago. Heather Chang at our institution looked at patients, and these are just a couple examples. Someone that blew right through docetaxel, abiraterone, enzalutamide, PSAs of 500, got carboplatin, and went undetectable. And this was a mutation carrier. And then again, 18 months later, again, rechallenge and down. This is another patient, came resistant to abiraterone, resistant to enzalutamide, came carboplatin alone, basically down, and it went to undetectable. This actually spawned ways to target these mutations better, and of course the PARP inhibitors. Again, very, very testable for those out there. And this was a very now kind of old study, but looked at patients with metastatic castrate-resistant way down the line, and they did harbor a mutation in this DNA repair pathway, and they were either given the next line of therapy, which was some form of hormonal therapy or chemo, or they were given a PARP inhibitor, single agent PARP inhibitor. And this was a New England Journal, like double the survival rate. Now you might say 6 months to 11 months for progression-free survival. Is that really that much? Well, it's a home run. I mean, it's double. And now we're doing combinatorial, this with other agents. And I think that we'll eventually get to the point where hopefully we can prolong even more. So again, PARP inhibitors. What about the future? And I'm going to end here because I really want to, a lot of time for questions, but I want to tell you what we're doing in addition to the future with germline genetic mutations. So I showed you this before. These 3,000 men, and again, the trigger was 3. After 5 rounds of screening, about 5% were diagnosed with cancer, and about half of them had bad cancer, is what I would say. In fact, if you look at this, and this just shows those that are diagnosed with prostate cancer, let's say BRCA2 positive or negative, the red is high-risk disease. So double the number in that group had high-risk disease, and half the number in the blue with low-risk disease. And again, clearly there's something going on. About 5% were diagnosed with prostate cancer, and about half of them were bad prostate cancers. And again, higher incidence of cancer, younger age, and so forth. So as part of our SPORE many years ago, we decided we got to do something about this. We've had a prostate cancer spore for now for over 20 years. It's between UBC, us, and Oregon. And we said, let's do a tailored prostate cancer screening trial. And why is that? Why do we need that? We need to do that for these people at higher risk because of this. Now, this was published years ago, 30 years ago. This was the thresholds a little bit like what you're talking about, age-associated thresholds first. But if you look at these are the age-associated thresholds that were put forth as, let's use these. It didn't fly for a lot of different reasons. If you look at this paper, not even in the supplemental files, in the main tables of this paper, and this is the one slide I show my primary care folks, and I think that especially the trainees here should understand this, is that if you look at the median PSAs in these age groups, look at these age groups, look how low they are. I see patients every week with newly diagnosed prostate cancer, and they'll be 60, 65 years old, and they'll be like, my PSA was fine. 5 years ago, it was 2. I'm like, well, 5 years ago, it was high. I was well above the median. I had my PSA checked like 3 or 4 months ago. I'm in the 50 to 59, and I'm well below the median. And I was very happy about that, because there is something to being below the median, which we can talk about a little bit later. But those are really low levels. Okay, and so again, we said to ourselves, how can we utilize this? We know there's a lot of prostate cancer down there. In fact, there was a really famous trial called the PCPT, prostate cancer prevention trial, where they gave patients finasteride or placebo. At the end of the study, everybody got a biopsy, regardless of what their PSA was. And these are the biopsy. At the end of the study, everybody got a biopsy, even if their PSA was normal, which a lot of them were, like hundreds, thousands. And if you look at that, and let's take a PSA between 2 and 3, and they just got a biopsy. And by the way, they were sextant biopsies. 1 in 5 had cancer, and 1 in 5 of those was bad cancer or clinically significant cancer. Okay, so there's a lot of PSA a lot of prostate cancer in normal PSA. We've known this for years, and so we said to ourselves, and Heather, myself, Pete Nelson, and others said, what should we do about this? And we published this. We said, in the carriers of these mutations, we should lower the thresholds. We should lower them to maybe just above the median. If someone's just above the median, look by MRI, look by PSA, more PSAs, look by maybe biopsy. And so this is what was born, the PATROL study, and will probably be the focus of the next 10, 15 years of my life. It's a multi-center, we decided let's do a multi-center study, prospective, for those who have these variants. Let's look at unaffected carriers of these mutations. Let's do novel biomarkers, and the primary endpoint was just to understand the natural history of this disease. We decided, and I'm a big tent person, which is like, let's take them all. Let's take all the mutations. I'll show you the distribution. We said, yeah, sure, BRCA 1 and 2, but how about everything else? ATM, BRP, CHEK, HOX, PALB. We said, let's take them all. And let's lower the thresholds. The minimum age is 40, concordant with the guidelines, start at age 40, have to be at least age 40. I have a lot of 30-something-year-olds coming to see me, but I say, we can't enter into this protocol until you're 40. And we lower the thresholds. We have MRI imaging. We have annual biospecimens, of course. And then at each visit, they fill out all these forms, and we get all their PSAs. And these are the thresholds. They seem really low. And sometimes I do think they're a little low. But I'm going to show you what the results are. They're preliminary results. They're unpublished. But for a man, PSA 50 to 59, if their PSA is above 1.5, we actually say get an MRI and maybe a biopsy. And we've been biopsying people, even with a clean MRI, with a PSA of over 1.5. And I'll show you the results. These are the sites. We started up in the Northwest, as I said, at Oregon and at the Fred Hutchin, University of Washington. And then Matt's leading the charge here. We have City of Hope, Northwestern. The Baxter Center at Penn is an amazing place. There's a whole institute based on BRCA, and I was just there 2 weeks ago at their symposium, and they put actually 200 people in this trial. Mass General also has a really big effort. Someone there named Kane Solari, a really great young urologist, and he's put on over 100 people, over 100. So we have over 500 people already on this trial, and it's really humming along. We're a biospecimen, we're a biomarker group, so we're filling up freezers at an alarming rate with biospecimens, and we're really into discovery about what we're going to do next. So I'm going to show you some preliminary results. Again, we have over 500 patients on the study. I'm going to show you about the first 250 or so patients who have actually had an MRI or a biopsy. So I wanted to show you a little bit of a flavor of who these people are. So first of all, they're people in their 50s. Their PSA is 1.1. What is that? That's over the median. It's low. I mean, when I show these results, oh, it's a low PSA. It's over the median, all right, for someone that's in their 50s. Very low PSA density, as you can see. Mostly Caucasian, and you can see the other ancestry. Mostly BRCA 1 and 2. So almost 3/4 are BRCA 1 and 2, and then there's a smattering of the other ones, okay? So how did they do? Like, what did we find? When we look at those, and an abnormal PSA, by the way, is age adjusted. It's not PSA of 4, all right? Normal PSA is below the age adjusted, so really low by age. And again, I can't walk through the whole thing. I will say that it's a little bit of a deceiving figure because it appears that we're using PSA first. Not always. There are some people that got MRI first, just so you know. I want to be transparent about this. But if you look at there, the first soundbite that I say is that we diagnose cancer in almost 13% of patients. And there was a lot of clinically significant, 8%, compared to the European trial, which it was like 5 and 2, 5 and 2.5. This is 12 and 8. I think that's because we're lowering our thresholds. I mean, the key question I hope is going through your minds are all you harming patients. We can get into that later. But if you look at the first soundbite, is we're diagnosing a fair number of cancers that are, and more cancers than the European impact trial. 2/3 of the cancers, of the clinically significant cancers, had PSA less than 4. We would have waited till the PSA of 4 if we just would have used traditional thresholds, as Matt was saying. Age-adjusted PSA, in other words, those very low PSA, still missed patients. So those age-adjusted, the normal PSAs up there, 20% of the bad cancers were in that age group. We're in that PSA group. So age-adjusted missed them as well, but so did MRI. And I think MRI works, and I think that, as Dr. Carroll said, MRI is the future. I'm a believer in MRI, but it still missed. So the negative predictive value of MRI wasn't great. You see the normal negative MRI, but there's some bad cancers in there. And there's some okay cancers, of course. What was the trigger? And again, just looking through what was the trigger for the biopsy. If you look at, or what was the result? If someone had both an MRI and a PSA patrol, meaning an abnormal, a very low PSA for a trigger, you can see the distribution. If they had both, if they had just the MRI as the first column, if they had both, so the MRI alone triggered a lot of biopsies, but there was a lot of negatives. If they had both an MRI abnormality and a low PSA threshold abnormality, it was much better. If it was just the thresholds, PSA patrol, and if they had all three, of course, a PSA over 4, most patients that had cancer had clinically significant cancer. Okay, so that kind of shows you. Of course, we're doing some more modeling and looking at performance characteristics, the really truly sensitivity, specificity of what thresholds we use. Again, PSA of 4, you can see that missed 14 cancers, 2/3 of the cancers, and you can see a pretty poor performance. But if you start using things like age adjusted, here we're missing less cancers, maybe missing 4. And then of course, we're combining them all together and doing DCA and some other analysis. We're just starting to show this. We didn't show this at the recent Canary meeting because it's honestly kind of a mess to look at. But the bottom line is that the PSA of 4 is sort of that teal green one coming down here, but anything else we do is better. So a higher line, the better the way that we can diagnose cancer, and almost anything else is better. Okay. And we can work through this. We have a lot of other, and I'm happy to answer questions. So I'm going to end with like the future and some other future efforts within this domain of genomic variants. And again, we know there's a lot of different classifications. These are some somatic variants. So these are like not only the germline, but also biopsying the tissue and looking at the tissue itself to see where there are other, and we know that not all prostate cancer is created equally. So one of the things we decided to do is years ago, now this is with Heather Chang, is something called SWOG 2210. I don't know if you have that open here, but it's for patients with localized prostate cancer that looks localized, at least, that have BRCA variants. We know that, and point 2 might have changed a couple of days ago, as far as is neoadjuvant therapy not considered standard of care with the Proteus results. Love to hear people's thoughts on that. I know Matt's tweeted about this quite a bit already. But right now, we see a man with high-risk prostate cancer. We just take them to surgery or go to radiation, but we're not giving therapies necessarily as a standard of care before surgery. This trial is saying maybe we should. What's really interesting in breast cancer and patients with breast cancer that have these variants the standard of care is to give them a PARP inhibitor or carbo before surgery. And what's amazing is in these women who have tumors in their breasts that undergo these therapies before surgery, at time of surgery, 30 to 50% of patients have no cancer left. So we know that these can work on tumors with these variants. So what we decided to do is, hey, we need to do a neoadjuvant trial of carboplatin before surgery. And again, this is really through SWOG, Heather, Tanya Dorff, the late Nick Vogelsang designed this trial. Very high risk and high risk patients who have the variants. We're giving them 4 cycles of carboplatin, taking their prostate out, looking to see whether they have CR rates. We're very early in the trial. We're honestly having problems enrolling people because a lot of people want hormonal therapy with it. And especially now with Proteus, I'm wondering what we're going to have to do with this trial, whether we have to add on ADT and APA. I mean, we'll see. But this trial is ongoing. Okay. We also have grouped together, as I said, we work with Vancouver quite a bit. They have a genomic umbrella trial. It's called GUNS for all terrible acronym. Coming from Canada, especially, they call it GUNS. But this is a genomic umbrella trial where we actually sequence patients. Now, these mutations are harbored in very few patients, so we decided we have to have a large trial, and this is a very complex trial. For all those people who have high-risk disease, we sequence them. And depending on their sequence, they get into an arm. If they have a PTEN mutation, they go to this arm. If they have a DNA damage mutation, they go to this arm. If they have a immunogenic high mutation, they get immunotherapy, and they get parsed out in this way. Okay. What's interesting is they had a lot of foresight. Of course, who funds this trial? J&J. Who funded Proteus? J&J. The backbone of this trial is ADT apalutamide. All right. So regardless, I'm not sure where this trial, but this trial is ongoing, and we're occurring in this trial as well. By the way, the immunotherapy trial is closing, arm is closing because of toxicity, and we're going to learn a lot. Yeah. There's some toxicity there. I'm going to close with this. This is the vision, all right, at least for the last half of the talk, which is that at least 2 in 10 might be eligible. 1 to 2 out of 10 are eligible for therapies. These patients, particularly the one that has BRCA, we're sending them to clinical trials. These people with high-risk disease. What's really, I think, more impacting is the first-degree relatives. And this is where I get most of my patients, particularly the brothers for the patrol study. The sisters go into our breast cancer and ovarian prevention trial. I didn't put it here, but all of our patients get pancreatic screening. They get endoscopy and ultrasounds, and we have a very high screening. It's a high risk clinic for screening for people with genetic mutations. And then importantly, of course, the children, the daughters and the sons, breast, ovarian, prostate cancer prevention clinics, patrol study for the sons. And most of our patients are coming this way from our clinics for prevention. So that's the vision. Just some take-home points. Happy to answer questions. Inherited susceptibility is very important. And again, as the original slide from Matt, across the spectrum, from screening all the way to metastatic castrate-resistant prostate cancer, there's really highly impacting results if you test your patients. Family history is crucial. I make that a point of every time I talk to a patient with newly diagnosed prostate cancer. I think the DNA damage repair pathway is probably the most relevant pathway that we're dealing with. And then, of course, the implications for downstream, because I think this will have long-standing generational impacts on our patients and help really hopefully cure and diagnose patients earlier. So thanks for your attention. I want to just give credit to all these people, particularly Kay and Solari at Mass General for some of the data, and the others listed on this slide in our funding agencies. Thanks.
Dan, amazing talk. There's a prostate cancer talk, and I'm fully fascinated the whole time. It's like
tough ask.
Thank you for being here. What percentage of the general population has one of these sort of
low
risks? And the follow-up to that is just, it got me thinking, should we be looking for more? Is it all just sort of screening with the family history? Because I'm seeing folks that are not, I'm more in the screening space, right? So.
Yeah, so the answer to the first one is low. I don't know the exact percent if you take all comers of all the mutations, but it's very low. We're like talking low single digits. I do think that there was a company that I don't know where it is right now, but they were really promoting, the heel stick at birth. You can get a lot of this, right away. They're talking about some of the prostate cancer risk from birth. right? And so that's why, and I wasn't really joking. I do think at some point in time, we will have at least the relevant pathway genes sequenced at birth. It will be like phenylketonuria, the test that we get for all the children and some of the relevant mutations, very likely. Because this one, if you think about it, if you knew about a BRCA2 mutation, you would really definitely start screening earlier. Tenfold increased risk of having clinically significant prostate cancer by 65. So we're not there yet. I'm hopeful because the cost of sequencing is it's going down by exponentially, outpacing Moore's law. You've seen those results. And I think that it's going to become very accessible, just even just spit in a cup now, but it's going to be something earlier.
So any man that comes in and they have a PSA that we're talking about,
yeah,
that we should always ask about family history. Is that?
I do. I mean, it's a simple ask. Any other cancers in your family, particularly breast, ovarian, and prostate? And pancreatic to a certain extent, but breast, ovarian, and prostate for sure. I mean, ovarian's rare enough that they have ovarian. If there's ovarian in the family, there's probably something going on. Larry.
Best prostate talk I've heard all year.
Okay, maybe the only one.
Totally fascinating. Kind of really down because we're very interested in this and hypospadias.
Oh yeah.
Kidney stuff. Are you doing? What testing would you actually recommend in 2026 for gene screening? Like we're doing whole genome sequencing, which is kind of like the gold standard. We're hopefully going to get every gene, we're going to get introns, exons, we're going to get variants of unknown significance, because we have no clue, and interpreting these tests is very complex. Versus the dream, I think, is to identify the genes that are at risk and then just do a panel of 50 genes, of 30 genes, and yes, we just have our babies, we just swap their cheeks or they're old enough to spit, and we don't really need funding for them. And 9% we get a good result. There's still a few where we can't get the DNA isolated properly. So in 2026 for prostate cancer, we say genetic screening.
Yeah, so I think it means a little different for who we're talking to a little bit. Like for you and I think we're doing whole genome. We are. I mean, we have our own in-house platform, Oncoplex, that we do everything. But when I'm out talking to the general population, I almost say anything's better than nothing. Like if they do a Myriad or an Invitae or whatever, they're getting the relevant pathway ones, like you say. They're probably getting enough of the relevant pathway for now for 2026. Eventually, those will be even more complex. But for us in academics, we're doing everything. But do we have to? We don't have to. We're just doing it because for research interests, of course. But it's good enough just to do the panel. For our point of care testing, like in our high risk clinic, it is the spit in a cup thing. Or we used to have them just go online to Color Genomics, $249 at home kit, online genetic counseling. Color Genomics sends them a kit, they spit, send it back, they send us a report, we're done. And a lot of people will take that because it's reasonably priced. I think that we will get to a point that I'm hoping the little cheek swab, or I was joking with somebody the other day, the circumcision skin can be sent off. How many of those do we do? And it's all right there. It just is. Of course, we would never do that without consent, of course, but it's there. I mean, it's what's happening in that tissue? Nothing. Okay. So, and how many millions of those procedures do we do yearly? But it will get to a point. Well, I hope that there'll be a swab at birth. Matt?
Yeah, my question with polygenic risk score.
Oh, yeah.
Last year, like, how do you? So, there's clinical tests out there now.
Mm-hmm.
So it's free. Like, how do you integrate that with the rare variants?
Yeah. So the question is the PRS. So we have a researcher, Bertrand Darst, who does PRS. So the polygenic risk score is sort of the huge panel, 249 or whichever one you use. And they are, again, that is the relevant at birth. So the PRS at birth, we all have a PR, we all have a signature that we were born with. And there are a couple PRS signatures, blood tests out there that look at risk. If one looks at the papers that are out there, and it's basically top decile versus low decile. And maybe we can get it to top quintile. So if you're in that top quintile, you have a much higher risk. What's really interesting is if you look at these rare variants in BRCA2, if you have a BRCA2, you overwhelm the top quintile. overwhelm it, so the scope is big. I think it will probably be a combination of an interplay between PRS and rare pathogenic mutations, because if you have both, then you're not very good. Yeah. And a lot of people do. So we have all those frozen specimens in the freezers as well as in past, but we can look at that. So we're going to look in patrol in the first, I think we're going to wait till we get to 1,000 patients in patrol, or 750. And then we're going to do the PRS on all those patients to see the interplay between the BRCA and the PRS. There's a reason why most of those biopsies are negative. So maybe it might just be time. I'm not sure. I am also putting the people that are 3+3 on patrol on active surveillance, but we've had a little bit more progression, which we can talk about at some point in time. Hi, Carissa. Thanks.
Going back to patrol, do you have a sense of how these various commercial biomarkers form in that population, like 4K?
Yeah.
Is that worth studying, or do you think it's about using another biomarker that's more tailored towards that panel of mutations?
Yeah, great question. Reading my mind. So I can say that we had when we first started patrol, we kind of hooked up with the MDX Health Group at the time. And as you know, they had the Select MDX test. And so they agreed to do the Select MDX on all these patients. So we did this actually on all but a couple of sites. Amazingly, they couldn't get urologists to do DREs or something like that. So we couldn't do, as you know, it's a post-DRE test. So we don't have it on all the patients. And we just got our first Select MDX results when we looked at them on the first, I think, 125 patients, something like that. And we showed that at a recent meeting. I don't know whether you saw those results, but they were good. In fact, the negative predictive value of Select MDX was 96%. Negative Select beat MRI. MRI negative predictive value was 89%, which is pretty good. But so the Select MDX works. Now, as you know, they're sunsetting Select MDX, and they're going to move to ExoDX. And I just met with the company yesterday. I talked about doing ExoDX on all the patrol patients because we have all the urines, and they don't have to be post-DRE anymore. So that site that didn't have a urologist to do DREs, we're going to get their urines. So I think we're running up against time, probably. Questions? Great, thanks. Perfect.